second season of series on controversies and consensus in orthopedics, what we need to know. This series is being conducted bi-monthly every Wednesday evening with an interesting guest presentation followed by discussion in each subspecialty of orthopedics. This particular season is dedicated to the young orthopedic surgeons having interest in each subspecialty of orthopedics with a goal of uniting skill with mastery, where the presentation is being moderated by an expert in that field. This platform is not only aimed at helping the young orthopedic surgeons to present their case and strengthen their communication skills, but also reach to a broader and more diverse audience through our OrthoTV channel partner, thereby increasing their visibility and exposure. This program is conducted under the chairmanship of Professor S.S. Mohanty sir and Secretary Dr. Ashish Phadnis, Dr. Swapnil, Keny, and myself, Dr. Deepak Gautam. We have a new member on board as Secretary Dr. Mrinal Sharma joining from today onwards. Dr. Mohanty is the professor and unit head in the Department of Orthopaedics at St. G.S. Medical College and Keny Hospital, Mumbai. He is an honorary consultant at Just Lok, Nanavati and Sushrusha Hospital. He is the past president at Bombay Orthopedic Society and an academician and a researcher. Today, we have three brilliant young orthopedic surgeons, one each in spine, pediatric orthopedics, and trauma, with an expert panel including Dr. Rohan Gala, Dr. Ravi Chauhan, and Dr. Parag. I would now like to call upon Professor Mohanty sir to introduce our presenters and proceed with the decision. Dr. Mohanty sir, all to you now.
Good evening, dear friends. Greetings from Mumbai, and welcome to the 5th episode of the second version of our controversies and consensus in orthopedics. Today we welcome Dr. Mrinal Sharma, who is part of the group. Good evening, Dr. Mrinal, for joining us today, and he will be also part of the team. So today we have three important subspecialties of orthopedics. First, let us move to the spine. I'll just share my screen. Okay. So to the spine case will be presented by Dr. Kuldeep Bansal. Dr. Kuldeep is a MS in orthopedics from University College of Medical Sciences, Delhi, and he's a fellow of National Board of and Spine Fellow from Indian Spinal Injury Center. He is currently working as spine surgeon in the Department of Orthopedics and Spine Care at Vardhan Multispecialty Hospital, Ghaziabad, UP. And to moderate here on the spine case, Dr. Rohan Gala is from Mumbai is there. He's a consultant spine surgeon at D.Y. Patil Healthcare and assistant professor in orthopedics in D.Y. Patil Hospital and Research Center. Dr. Rohan is trained in spine surgery at Park Clinic and Kotari Medical Center, Kolkata, and several other traveling fellowships also at Ganga Hospital, University of Malaya, and Aras University. He is a member of Education Committee of ASSI, Research and Mentorship Committee, SICOT, and reviewer spine section of Indian Spine Journal, Indian Journal of Orthopedics, Journal of Orthopedics, and Journal of Clinical Research. Thank you, Dr. Rohan, for joining today. And let me stop sharing the screen, and I welcome Kuldeep to present his case. Could you unmute yourself, Kuldeep? Yeah.
Good evening, everyone. Thank you, OrthoTV, to giving me the opportunity to present the today's case. So I am presenting my case. Can you move next, please? So today's case is 72-year-old male who presented to us with a progressive back pain. Next, please. So the patient was treated for the osteoporotic fracture in an OPD on the conservative basis, and he was developing a progressive kyphosis over 1 year. And he had a known history of chronic kidney disease and hypothyroidism. As of now, patient was not having any bowel bladder involvement, just a back pain and progressive kyphosis. Next, please. So if we see the X-rays, the initial X-rays, we can see there is a wedging of the D2, L1 vertebra, and over the progressive X-rays, we can see there is the intravertebral cleft. Next, please. So on examination, when patient landed in the OPD, there was a tenderness in thoracolumbar junction and kyphotic deformity at thoracolumbar junction. On neurological examination, roughly power was intact by 4/5 bilateral lower limb, and there was no UMN signs. Next, please. Next, please. So, as a protocol in our institute, if any patient presented to us with the deformity, so we will get a whole spine standing X-rays to rule out the magnitude of the deformity and how much we need to correct. If we can see that on the standing X-ray AP view, the patient was barely maintaining the sagittal balance, but over the lateral view on there was gross kyphosis at the thoracolumbar junction, and patient was sagittally mal-aligned, and there was positive sagittal balance. Next, please. So if we measuring the kyphosis, there was 62-degree kyphosis, which was correcting on the prone lateral position. Next, please. So the kyphosis which was present around 60-degree on standing view, when we make the patient lie down and we took the X-rays, we can see that it is reducing to 26-degree. So there was definitely a dynamic instability at the fracture site, which was developed chronically. Next, please. So as patient is developing progressive kyphosis and there was difficulty in walking, we took up the patient for the surgery, and to work up the patient, we get the CT scan done. And over the CT scan, if we can see that there was only shell of bone was present at the fracture site, with no cancellous and cortical bone present in the fracture itself. So it's just an empty shell over which the proximal segment of the spine and the distal segment of spine are colliding. Next, please. Next, please. So over the MRI, we can see that the posterior-superior fragment of the fracture is compressing over the conus area, which is causing the patient radiculopathy as well as difficulty in walking. Next, please. So on this MRI section, sagittal section, we can see that there is a posterior-superior fragment of the fracture is impinging on the cauda. Next, please. So so we are discussing with the old osteoporotic fracture, which resulted in kyphosis due to intravertebral instability. Next, please. So we took up the patient for the surgery as there was no bone present in the anterior column. So we took up the patient for deformity correction. We do the long segment fixation with cement augmented screws along with interior reconstruction by putting the cage. So my next case is 27-year-old male, which is presenting with a progressive back pain and difficulty in walking. So if we see the X-ray grossly appear degenerative spine. There was no fracture as such, and there was at many level in the lumbar spine there was vacuum sign present. Next, please. Next, please. So if we see the MRI, we can see there is a collapse of the L2 vertebra, and there was some signal and some deformation of the conus area also present over the sagittal MRI. Next, please. Next, please. So Poonam, can you go one slide back? So, but when the patient presented to us, patient was presented with the dense paraparesis. So on the X-ray, there was no such compression, but when we get the dynamic MRI done, we can see that the posterior superior fragment of the fracture is impinging over the neural element, which is causing the neurological deficit. So we took up the patient, we do the fixation we did the decompression, we removed the pedicle, and we put interbody cage anteriorly. Next, please. Next, please. So osteoporotic fractures is an umbrella consisting of a fracture happening after a trivial trauma or no trauma at all, and it can result in pathological fracture, instability in the fracture, sometime post-operative kyphosis, along with adjacent segment fracture, plus minus neurological deficit. Next, please. So the osteoporotic fractures, if managed timely, can be managed with in the first, like if we see the first X-ray, it can be managed by just by a vertebroplasty. It might be managed by a kyphoplasty. It can be managed with a short segment fixation with cement at the index level. It can be managed with a long segment fixation with cement in the index level, or it can be managed with the long segment fixation with all cement augmented screws, or it can be managed with the posterior long segment fixation with the anterior column reconstruction. Thank you.
Excellent cases, Kuldeep. Fantastic cases.
Thank you, sir. Thank you.
Really. So just
keep
before
the presentation slides intact. Poonam, ma'am.
So before I hand over to Rohan, just for certain clarification. So both the cases were not fit for vertebroplasty, correct?
Yes, sir.
So for vertebroplasty, because if you inject cement, there is a possibility of extrusion of the cement in your cases because there was no boundary of the no cortical boundary around that bone,
sir. Yes,
isn't
sir.
it?
Yes,
so
sir.
did the radicular symptoms subside in the first case after you operated?
Both the patients improved after the surgery. Even radicular symptoms also, even they improved in power also, motor power also.
Okay. Okay.
And
So
sir, we
can
have
you just
published a paper also in the Global Spine Journal. The patient who has a dynamic instability, just correcting the deformity or just correcting the dynamicity of the fracture site, resulted in great results.
so indications of vertebroplasty, can you just tell
Yes,
in which cases
sir.
do you do vertebroplasty only?
Sir, if there is just 10% of the height loss and on MRI just there is a edema, marrow edema over the MRI, and there was no improvement over 3 weeks to 6 weeks in the patient symptoms, and there was no kyphosis, no adjacent segment pathology, and patient
So
is sagittally aligned.
patient should be symptomatic. Suppose patient is not symptomatic, but there is a collapse. So to prevent
Then
a further progression of the kyphosis, do you do eventually you saw that is a there is a collapse. So
sir,
you do
if there is a collapse and if there is a collapse and a patient is asymptomatic, so we need to fix it. Not just doing a kyphoplasty or vertebroplasty will not help, because we have seen that even after vertebroplasty, patient had a symptom of failed vertebroplasties.
okay.
So we need to see other parameters also, not just the fracture. We need to see the sagittal parameters also, and we need to see how much the compression is there. What is the MRI findings? We have to see whole of the radiology to go for any procedure.
Okay. Over to Rohan, please. You have to unmute yourself.
Kuldeep, thank you, sir. Kuldeep, very nice cases, but I mean, you have presented them really well, and I totally agree with you that these lesions actually, kumal lesions. Uh, am I audible?
Yes.
Yeah. So these kumal lesions actually are responsible for two main important symptoms that these patients come to you with. One is the transitional pain. This pain actually is maximum when the patient tries to get up from supine or when the patient is side turning in the bed, especially the thoracolumbar lesions. Second is delayed neurology. So if you understand the history of these lesions, they will not come to you on day one. I mean, it is only after like the intravertebral non-union has set in, which is after 3 to 6 weeks, when you have that cleft or when it is the inability of the fracture to unite will actually cause that collapse. And if it is a burst fracture, as you correctly said, I mean, certain centers won't be having a dynamic MRI, but it is very easy for us to understand that it is the repetitive abutment of that retropulse fragment over a certain amount of time which will cause these delayed deficits in these patients. So a simple weight-bearing X-ray in the form of a sitting X-ray or perhaps a standing X-ray, as you correctly show, versus an MRI which is most likely done in a supine position will actually kind of demonstrate instability.
Yes.
Now, along with that, I want to reiterate a very important point is that, okay, these were male patients, but the algorithm to manage these patients and to establish the diagnosis of osteoporosis, you need to do certain serological investigations also before concluding that this is osteoporosis. Like, you should always get a CBC, ESR, and CRP done to know whether it is an infective pathology or a serum protein electrophoresis. Like, this is the basic things that you can do on an outpatient basis when the patient comes to an say on an acute onset, and then you kind of see him and observe him over 3 to 6 weeks. Secondly, the management options also depend on a lot of things like the DEXA scan. The DEXA scan will always tell you what you're going to deal with intraoperatively. Now, this is not absolutely picture perfect, but eventually it depends on what we find and what is the hold of the screw intraoperatively. And when we do that, we just have to have a wide range of surgical armamentarium when we go in, like from dual threaded screws to say larger diameter screws, like fenestrated screws, a couple of cases that you had shown, even sublaminar wires, to augment the construct, and cement. And now people have started using transpedicular cages also, just so that that collapse can be prevented by pushing in bone first and then a cage via the transpedicular route. One more thing I wanted to add was also that if at all we are considering coronal and sagittal alignment, like the most coronal and sagittal optimum alignment, a lot of surgeons also now believe that you don't need to decompress these things. Like even with a deficit, say like a 3/5, which has developed over a certain amount of time, and we have established the diagnosis of a Kummal lesion or an unstable fracture with collapse and increasing kyphosis leading to delayed deficits. On positioning, like you said, if it opens up to an extent where you have a reasonable amount of anterior vertebral height, then once you have the coronal and sagittal alignment, you may just get away by even percutaneously fixing. And the index vertebra, that means the fractured vertebra, wherever that fracture is, that can be augmented by various methods, like even a cage, or for that matter, cement, or for that matter, those stents that have come. So index vertebra is also of equal importance here, because you don't want to do an extensive job here, because these patients are at risk of, they have an increased risk of morbidity and mortality. They have comorbidities. So overall, the surgical procedure should not be morbid and as minimal as possible with the maximum outcome. And
how do you
osteoporosis
decide, just for my
Yes,
knowledge,
sir.
how do you decide how many segments are to be fixed? One vertebra is collapsed. So short segment
sir,
fixation or long?
Yes, sir. So that depends on how much is the collapse and how much is the collapse opening up. Like if I see that there is a reasonable amount of vertebral height which I can get on positioning, because in position these thoracolumbar junctional fractures will open up. So it is like a hyperextension at that level. Plus the anesthesia also aids us. So that also actually indicates the degree of instability which is very high. So I mean there are various methods by which we can do. A lot of surgeons prefer a standard 2 up, 2 down, either open or percutaneously with vertebroplasty or kyphoplasty at an index level. Some surgeons even prefer fenestrated screws with a short segment construct where they pass screws through the index vertebra and then augment it with cement. So you have fenestrated screw in the index vertebra also to provide absolute stability plus a 1 up, 1 down. But these thoracolumbar junctional fractures have to be fixed in such a way that they don't fail over time. Some people have started using sublaminar wires. I mean, most of them use that, and now sublaminar bands are also available where they tie it to the rod to kind of just hold that construct, because it is a race whether that osteoporosis is being reversed over time versus your construct not to fail. So essentially, we are treating eventually a medical disease, which is osteoporosis. This is just as a splint to prevent prolonged recumbency, to make sure that the patient's health-related quality of life is improved, and to reverse any neurology if present.
So was the fixation adequate in the first case? Dr. Rohan, do you
I have which the first case was the one where he had used a cage, is it?
Yeah,
Yes.
cage with almost
Yeah,
no
so-
vertebrae fracture fragment.
Right. So I feel that the anterior reconstruction that was done was thorough, according to me. I mean, if you would have only fixed, like stabilized 3 up and 2 below without addressing that index vertebra, I would have felt that the construct is inadequate, because there the vertebra still did not open up to a significant level which would help me to kind of augment it with something where I could restore it a little more than usual. So he did a thorough job by going wider. He passed in a cage, which was a very important stretch. The reason why these things fail is mainly because of anterior column failure.
Great.
They will come to you only because the anterior column has failed. It has not been stable because of whatever reason. Either the bone has not united, or the graft has not been taken up, or the cement has been extravasated, and still there is some instability between the disc space and the burst fracture. But they fail mostly because of anterior column failure.
What do you put in the cage? Bone graft or cement?
Just
Bone graft.
Sir,
Bone graft.
in the
Always?
cage,
graft.
yes, sir. So transpedicularly, if I'm going transpedicular, I would first, like any other approach, would do an impaction grafting transpedicularly. I can mix it with something like a beta tricalcium phosphate and bone graft together and impact it anteriorly. And then just to maintain that height between the two end plates, which have like come so close and approximated with each other, but now have opened up, I would pass in a cage. A cage is nothing but a solid strut that would just prevent that column failure, and rest I would really depend on the anti-osteoporotic medications for this, so that everything unites over time.
Okay. I think let us move ahead with the next case.
Thank you,
Deepak.
sir. Thank you again.
Thank you, Kuldeep. Thank you,
Thank you,
Dr.
sir.
Rohan,
Thank you.
Good case.
for
both
that
the
excellent
cases
case.
are
And
right. Yeah.
really I enjoyed about osteoporotic treatment, which is a common thing, which is every orthopedic surgeon should know. So, friends, let us move ahead with the next case in pediatric orthopedics. And to present the case, we have with us Dr. Himanshu Gupta today. Dr. Himanshu is a MBBS from University College of Medical Sciences, Delhi, and MS also from the same institute, and also DNV Ortho. He is currently working as a senior resident in Dr. Babasaheb Ambedkar Medical College in Delhi. He has delivered award-winning paper presentation in national conference, multiple publications in index journals, and has a keen interest in pediatric orthopedic and deformity correction. And to moderate the case, we have with us Dr. Ravi Chauhan. And I think Dr. Ravi is not unknown to the Indian orthopedic crowd, is very popular. And is a consultant Department of Orthopedics at Sir Gangaram City Hospital, New Delhi, India, and specializes in pediatric orthopedic and limb reconstruction. And is the editor of Orthopedic Clinics, former secretary and current treasurer of Ashami India, executive committee member of Delhi Orthopedic Association, member of IOA, Elizabeth Committee, and life member of various committees, IOA, DOA, POSI, and so many committees. And overall, I would tell Dr. Ravi is a good human being. Thank you, Dr. Ravi, for joining today. And let me stop sharing the screen, and I now welcome Dr. Himanshu to present his case.
Yes, sir. So are my slides visible to all?
Yeah, visible and audible.
Yeah. So good evening to all the panelists. I firstly like to thank OrthoTV to give this platform to talk about neglected non-TGF fractures. Moving on to pediatric orthopedics, I'm Dr. Himanshu, and I've done this presentation under the guidance of Dr. Ankit Khurana. So a very brief introduction. The Monteggia fracture is very well known as radial head dislocation with proximal ulnar fractures. Now, this topic is regarding the controversies and consensus in orthopedics, and we'll be dealing a lot during my presentation. The first controversy is when to call this Monteggia fractures as neglected. So recent studies recommend around 4 weeks after the injury as the dividing line for NMF, because at that time, the malunion of the ulna has already been solidified and it is impossible to close reduce the radiocapsular joint. Now, what is the challenge? There is a very high rate of misdiagnosis, up to 28%, and there are 3 possible causes to this. First is the anatomical cause. The sequential development of the radiocapsular and the distal physes around the elbow makes the judgment of the alignment of radiocapsular joint very difficult. Second are the patient-related. Our patient cohort are very apprehensive to get a good radiological or a clinical examination done. And third are us. We as orthopedic surgeons are too much fixated on a fractured ulna and reduction of the ulna. And sometimes the displaced radiocapsular joint can be missed by us. Essentially, also in just a plastic deformation of the ulna, where to a untrained eye, it can also look like a grossly normal X-ray as well. Now, what are the possible solutions? For a condition such as NMF, almost everything under the sun has been described, right? There has been just isolated open reduction. There has been 2-stage procedures. There has been internal fixation, external fixation, combination of the both. There has been different type of osteotomies that has been described. Step cut osteotomy. There has been oblique osteotomy, flexion osteotomy, flexion distraction osteotomy, various kind of approaches. So all these options lead to a lot of controversies, lead to a lot of confusion, but the broad guideline is always the same, that we need to correct the angular deformity of the ulna, we need to stably reduce the radial head, and we need to restore the proper alignment of the radiocapsular joint. This is the most important, restoring the proper alignment of the radiocapsular joint. So in a formula form, I'd like to give as open reduction of the radial head with flexion osteotomy of the ulna plus minus augmentation procedures. These augmentation procedures can be either ALR, annular ligament reconstruction, or a radiocapsular wire. See, we have our own concerns regarding the radiocapsular wire, especially the radiocapsular wire breakage in young pediatric population, also possibility of radiocapsular arthrosis, also possibility of stiffness. Talking about ALR, see what to do in ALR, what is the controversy again? Now, in this current day and age, artificial intelligence has integrated with the search engine so beautifully that our literature search has become very easy. Even if you put this keyword in Google, it'll give you a straightforward answer that annular ligament reconstruction in neglected Monteggia is not required. You need not even touch any link. It'll just give you a straightforward answer. But of course, things cannot be as straightforward as that. A lot of studies suggest that yes, there is an improved outcome after ALR. A lot of studies suggest otherwise, that no, it does not provide any functional outcome, any better functional outcome. Probably making a non-physiological sling around the radial neck can lead to ischemic changes in the growing radial head. But these 2 articles, one being a review analysis and another being a prospective study, give a very straightforward yet a diplomatic answer. They say that osteotomy in most of the cases is sufficient. Annular ligament reconstruction or RC wire should be done based on intra-op radial head instability. Now, this was a very basic introduction, and with this background information, I'd like to start on my cases. The first case was of an 11-year-old boy. He had a 2-year-old history of trauma and was treated elsewhere. He had complaints of loss of range of motion, bony prominence at the elbow. So this was the X-ray that the child presented to us with. So now we can see a mature malunion of the ulna and an anterolaterally displaced radial head. This is a classical Beddoes type 1. Most of the patient will present us with these kind of X-rays only of neglected Monteggia fracture. Of course, we took the patient into the operating room. We gave him general anesthesia. The bony prominence on the antegrade fossa was, of course, the radial head, which could not be close reduced. Now, on testing the pronation and supination, the arc was restricted. There was cross valgus instability, which was expected. And on testing the flexion and the extension, we could see that there was terminal restriction of the flexion arc as well. We opened the elbow through the lateral approach, saw that the radius head was again anterolaterally subluxed. We debrided all the soft tissue. Straight ahead went on to the osteotomy of the ulna. We did an osteotomy. We did an oblique osteotomy. Even after doing the oblique osteotomy, we were not able to reduce the radial head. So we resorted to an oblique flexion distraction osteotomy. This was an 11-year-old boy. So he had a good amount of girth in his ulna. So we decided to fix by a 6-hole LCP plate. Now, this was the intra finding when we fixed the ulnar osteotomy. Now, during the flexion and the extension arc, the radius is completely stable. During the pronation and the supination arc, the radius is very well fitting in the radiocapsular joint, and we decided to call it a day. This was the immediate post-op X-ray. We were a bit concerned that the gap at the ulnar osteotomy site was too much. But again, after following up the patient around 2 to 3 months down the line, this is around 2.5 months down the line, we can see the ulnar osteotomy has beautifully consolidated and the radius is very well sitting and the radiocapsular joint is very well aligned. This child presented with near normal range of motion of the left elbow as well. Moving on to the second case. Now, this was a 5-year-old boy, had an 8 months history of trauma. Complaints, again, the same was restriction of range of motion. This is the X-ray that the child presented to us. Now, similar type of picture, a malunited ulna, anterolaterally displaced radial head, a classical Beddoes type 1. On examination, he had severe restriction of pronation and supination as well. Again, the patient was taken into the OT, open through the lateral approach. Now we can very well see that the radial head is anterolaterally subluxed as compared to the capitulum, and we found that the annular ligament was deeply interposed in the radiocapitular space. These kind of deeply interposed annular ligaments often preclude us to a close reduction in the initial attempts. Now we did removal of this annular ligament. Straight forward, we moved on to the oblique osteotomy of the ulna. Now, unfortunately, for this child, when we did an oblique osteotomy, flexion osteotomy, when we fixed the osteotomy, we were able to reduce the radial head, but even the slightest attempt of range of motion led to the radial head dislocating outside. So what were the options? One of the very classically described option described in 1965 is the bell toss procedure. Now, this is a very, very well-known procedure and has very well established documented functional outcomes as well. Now, this is the basic diagram that what we do. Now, this is we take the lateral sleeve of the triceps, around 6 to 8 centimeter lateral sleeve of the triceps, which is still distally attached to the olecranon. We use it as a hammock and sling it around the radial neck, and we can either do a transosseous fixation with screws, or we can stitch it on to the proximal part of the sling itself. And that is what we did. We extended our incision a little bit more proximally. This is the lateral head of the triceps, which is exposed. We took around 6 to 8 centimeter long sleeve of this lateral head of the triceps. Now you can very well see that even after fixation of this osteotomy with plate, the radial head is grossly subluxated outside. And in this case, this is what intra-op finding warranted us that we should do an ALR. So this is a 6 to 8 centimeter sleeve of the triceps, which we took out and rotated the sleeve around the radial neck and stitched on itself. Now, after doing this, we could see that on flexion and extension, and also during supination and pronation, the radial head was very well stable and the radiocapitular joint was very well aligned. This is the immediate post-op X-ray. We can see that the ulnar osteotomy is fixed and the radiocapitular joint is very well aligned. Now, an interesting third case. This child presented to us this week only. He had an history of trauma 14 days back, a 7-year-old boy. Again presented to us. Again, neglected, not a neglected now. It's a 14-day-old injury. It's a Monteggia fracture, simple Monteggia fracture, which was caught 14 days down the line. Now, in this case, what we did, we attempted a close reduction. And to this boy's destiny, the close reduction was successful. We were able to reduce the radiocapitular joint, and now this child is in our follow-up. So what are the take-home points? Now, when we are dealing with the neglected Monteggia fracture situation, we need to have an high suspicion, detailed examination, and thorough evaluation. If the child has a good clinical examination and evaluation done, we need to reduce the rate of misdiagnosis in these children, because see, delay more than 4 weeks, you have a very good challenge in your hands. Now, what is the dictum? All patients require an osteotomy of the ulna. Most of the patients require open reduction of the radial head. Many of these patients, despite having long history and a prolonged dislocated joints, will have a good functional outcome. Some of these patients would require an augmented procedure such as annular ligament reconstruction, but none of these patients should be managed conservatively. Thank you.
Thank you. Thank you, Dr. Himanshu. Excellent presentation, excellent intra-op demonstration, as well as a follow-up of the cases. That was really nice. So only if intraoperatively, if the head is still subluxated, then you do annular ligament reconstruction. Otherwise, if it is getting reduced and stable, you do not require annular ligament reconstruction. Correct?
Absolutely, sir. Actually,
Yeah.
the recent literature is of this opinion only, that annular ligament reconstruction should not be a predetermined step when you take the patient for OT. It should always depend on what is the intra-op findings that you have. If you think that your osteotomy is well fixed, but even on slightest flexion extension or pronation supination, or the radius head is not sitting inside the radiocapsular joint, it is then strongly advocated you should look forward to ALR.
Okay. And how do you take out that strip of lower third of triceps, then you suture it out to itself, or how do you suture that?
Sir, actually, there are two procedures described. Initially, it was described that you can also fix it by transosseous screws, but if not, you can also use Prolene sutures and fix it on itself. Both of them give good results. In our case, we did Prolene suturing on the sling itself, and we found that the radial head was completely stable.
Okay. And you don't pass a K-wire, transcapitular K-wire through the radial?
No, sir. Actually, as I talked,
It is-
radiocapsular wire has its own set of disadvantages, especially in pediatric population. If the child is not compliant, it can lead to radiocapsular wire breakage, which is a very big challenge again. And most of the people advocate, see, radiocapsular wire is used to provide additional stability to radiocapsular joint. But most of the people then advocate, if your joint is not stable, you should better go for annular ligament reconstruction, which is a near physiological thing, rather than doing a radiocapsular wire, which gives the same result.
So in no cases, radiocapillary wire is required, according to you.
Sir, we at our center do not put radiocapsular wire. If the radial head seems to be unstable intraoperatively, we decide to go for annular ligament reconstruction.
Thank you. Over to Ravi, please.
Thank you, sir. Himanshu, these were good cases actually that you have presented. Am I audible?
Yes, sir,
Yeah,
you're
yeah.
absolutely audible.
Taking from the third case as a first, you just mentioned that acute annular ligament reconstruction should be done whenever you are finding a radial head outside after reduction, after doing all the soft tissue and everything. That was your point. So I need to make a comment there. Basically, annular ligament reconstruction, it's not the thing which should always be done when your radial head is dislocated and unstable, because whenever you are reducing openly via the open reduction, then the two things that matter the most are the clearance of the radioulnar and the radiocapitular space. Because after a long term of negligence, after 1 year, 2 years, or even 6 months, or even 3 or 2 months, a lot of soft tissue is found. You will find the scar tissue between the radioulnar and radiocapitular area. So always better to go for the clearance of that, along with a flexion distraction osteotomy. These are the two prime requisites. If after these two things, definitely in more than 90 cases, your radial head will be stable. And even if after that, if your radial head is not stable, so better to go for further flexion or distraction in the osteotomy to make it more stable. Because annular ligament, you were lucky enough in your case that you went away with that. Otherwise, it's not always useful that much of keeping that kind of unstable radial head into its position. So I always prefer the two important thing is always concentrate on the flexion distraction osteotomy and the clearance of the radiocapitular and the radioulnar area of the scar tissue. And thereafter check the stability in both. You have very well told that in the flexion extension and pronation supination, definitely the check should be done in both all these basically movements. That's most important. And regarding the transcapitular wire, you have rightly pointed out, it's not necessary and it's have all its known complications. So, but there are conditions, especially in old cases, sometimes you may require transcapitular wire just to provide an extra stability. But whenever, because there are certain surgeons who prefer, like it's like doing the DDH, reduction of a DDH, sort of. So some of the people, they prefer the wire there as well. So whenever anybody is using the transcapitular wire, it's better not to use it. But even if you are using it, better to take care of that. The thickness of transcapitular wire should be quite good enough. so that it will not break. That's most important thing. And the another thing is always better to reinforce your cast with Scotch cast if you are using the POP cast. Because in case your cast child breaks the cast, then definitely the chances of breakage of your K-wire will be much, much more. So better to take these two precautions, means your cast should be quite good enough. And the another thing is the thickness of your K-wire should be good enough. That's my take regarding the ALR and the transcapular wire. And you have really presented well all the three cases, taking into consideration all the scenarios. And the first one case, after 2 years of presentation, it was done quite well. So, and definitely the problems actually in these cases arises with the misdiagnosis in the acute setting. Whenever
Absolutely.
most of the general orthopedic surgeons or somebody who is not very much conversant with these kind of injuries, especially in children, they do miss the diagnosis. Some of the even the orthopedic surgeons, just leave aside some of the pediatric orthopedic surgeons, they may lose, they may miss the diagnosis. So that's why I always prefer that better to concentrate even on the plastic deformation of the ulna. That is also most important. That's the main part of negligence of these injuries. Because even if you are having the fracture of ulna, then it's a straight away you can find there. But most of the missing diagnosis is in the deformations of ulna. So better to take care of it. And whenever you are doing, another important thing to be take care of in these kind of fractures, that in acute setting, when we are reducing these fractures, so better to reduce the ulna properly. And after reduction of the ulna, better to keep the ulna straight border. Because if there is an angulation at the ulna, especially the anterior angulation remaining, then definitely it will further dislocate the radius. And these children do come to us after a certain period of time that reduction, it was diagnosed in the acute setting, it was managed with the cast, but later on after 2 or 3 months, it is again displaced. So it is again displaced because of the redisplacement of or angulation of the ulna, actually. And with respect to your second case, I think it was the proximal ulnar fracture or the third case.
It was the third case. It is the acute setting.
It
Yes,
was the
proximal
third
ulnar
case.
fracture. Yeah.
So whenever we are having these kind of proximal ulnar or the like comminuted ulnar fractures, so better to fix the proximal ulnar fractures in a quite well manner. So especially when you are having the ulnar fractures like displaced ulnar fractures, so better to use the TENS or even the plates for the proper fixation of the ulna. Because even the slightest angulations of ulna, especially the anterior angulations, can redisplace the radial head. So one can't afford the redisplacement of the radial head. So better to avoid the angulations. So that's why whenever we have the ulnar fractures, so better to stabilize it with either with the TENS, like the intramedullary nailings, or sometimes with the K wires, or sometimes even if it is required with the plates as well. There is nothing wrong in using plates. For flexion distraction osteotomy, we are using plates. So there is nothing wrong in fixation of these ulnar fractures with the plates in order to keep the radius in its place. Yeah. And any other questions, or Mohanty sir?
Excellent. No. Yeah, Deepak, any question? Deepak, you are there. Parag, any question?
No, sir. No, sir.
Dr. Parag, I think you can
Dr.
give some
Parag? Okay. Thank you. Thank you. Excellent case. Lot of learning points.
Good.
Actually, in the course of these presentations, I personally gain a lot, because these are the things which I'm at least not reading nowadays. Nowadays, I'm confined to arthroplasty, but at least being in a teaching hospital, it gives lots of knowledge and for management of the cases of the spine as well as the pediatric case. Thank you, Dr. Himanshu. Thank you, Dr.
Thank you so much, sir.
for this case. So friends, let us move on to the last part of this today's program, the most challenging, trauma cases. So for that, we have with us Dr. Manish Baviskar today, who is the Associate Consultant Trauma and Joint Replacement at Jupiter Hospital and in Thane. And he has got keen interest in complex polytrauma management and robotic joint replacement. So to moderate that, we have Dr. Parag from Mumbai, Dr. Parag has been practicing as a consultant hand surgeon since 2011. He's an orthopedic surgeon and then received a training in hand surgery at various national and international renowned hand surgery centers. He has experience of performing over 4,500 simple to complex hand surgeries. Oh my God. Last 13 years. And he has delivered talks. So of course, we know, Parag, that you have been delivering talks in IROC and various national and international conferences, and is the director and consultant of hand and reconstructive surgeon at Pinnacle Orthopedic Center in Thane, and is also affiliated to the largest tertiary care corporate hospital in Thane, and that is Jupiter Hospital. And he has a keen interest in good volume of work in brachial plexus, peripheral nerve injuries, wrist injuries, etc. And is now ex-executive council member of Indian Society of Surgery of the Hand and member of brachial plexus group in India. And he's at present executive council member of Bombay Orthopedic Society. Thank you, Dr. Parag, joining today.
Thank you.
Now, I'll stop sharing the screen and now invite Dr. Manish to share his screen and present the case.
Hello everyone, can everyone see the screen, please?
Yeah, we can hear you and see.
So, good evening. Thank you, Dr. Mohanty, sir, for giving this opportunity. I have the good fortune of having the moderator, Dr. Parag, who also helped me in this case in a big way. So, thanks, Dr. Parag, for this. So, I'm going to present a case of a post-mangled extremity, stiff elbow and forearm. So, this was a 27-year-old software engineer who had a very bad injury. He's a right-hand dominant gentleman who had a side swipe injury of the right elbow back in Pune. And from there, he was brought over here. So he had a severely comminuted internal compound degloving injury of the arm and the forearm, the compound fracture dislocation of the elbow with a comminuted fracture of the proximal radius ulna, capitulum, and the trochlea, but a sensate vascular limb. So initially in emergency management, first of all, clinically, when we opened up for surgery, he had complete loss of the common extensor origins and severely contused forearm musculature in the proximal 1/3 of the forearm. He had a huge internal degloving moral level lesion going way up, proximal up to the dental insertion. The triceps was completely contused and lacerated, which was also debrided off. So we managed to reduce the fracture back in position and hold it with multiple K wires and debride the wound properly. By day 4, we planned for a definitive fixation for the surgery. We also involved our in-house plastic surgeon for adequate wound cover for this degloving wound. So in this case, what we did was we fixed the radius and ulna with multiple DCPs, and we fixed the trochlea with HCS and the intraarticular fracture. We also fixed the anterior capsule of the elbow with suture anchors, and we put in an initial VAT helped by the plastic surgeon. And in the second setting, once the wound granulated, the plastic surgeon grafted the wounds. And this was the image at 6 weeks post-op. Not much improvement by 4 months post-op. This was at 4 months, the presentation. When she used it was just a restricted elbow extension. And difficulty in the wrist extension and thumb movements. Hence, we provided a tendon transfer for him, in which we transferred the flexicarpal ulnaris to the extensively determined communis for finger movements. And the palmaris longus to the EPL for thumb extension. This was 1 year post injury and about 6 months post tendon transfer after adequate This was the range of movement at 6 months post tendon transfer. There wasn't much improvement in the wrist extension, the elbow extension, but he had managed to get the wrist extension and thumb movements. Supination also was much better. Wrist and hand functions were much better. After achieving all of this, he now desired to have more pronation. Now he's a software engineer, remember? So he wanted to have pronation so that he could type on a keyboard. At the same time, the ulnar implant, which was prominent underneath the healed skin graft, he desired that to get removed too. This was his clinical presentation at the time. Hardly any pronation beyond the neutral. So we wondered whether what was the difficulty in the pronosupination, whether it was a proximal radioulnar synostosis or a malunion of the proximal radius ulna. You can see that the radial bow in the process was obliterated. Was it the DRUJ instability, or whether it is a soft tissue contracture because of the skin graft. Hence, we did a CT scan, which also proved that there was no synostosis in the proximal radioulnar region. So the options for this conundrum were a corrective osteotomy and revise both the fixations, or we fix on a single bone of the forearm by fixing only the distal ulna with the proximal radius, either of the above, plus an intraosseous membrane release, or a direct procedure with an ulnar implant removal. The review of literature, there aren't much articles spoken about discussing all of this. This article, which I could find, it has done a study in which it has done there are a lot of studies done on obliteration of the intraosseous space or angular deformities, but the magnitude of angular deformities which could cause difficulty in pronosupination were not studied well. In this landmark article in 2002, they hypothesized that if the axis of the pronosupination passes through the intraosseous region less than 2 centimeters radioulnarly and 0.8 centimeters anteroposteriorly, then we can achieve more than 40 degrees of pronation and supination. Any deviation from this region can result in significant loss of pronosupination. Another study, which also has done a study on 3-dimensional deformity analysis of malunited forearm diaphyseal fractures, also did a study on, they assessed the rotational angular deformity based by superimposing the deformity on the normal contralateral side, and they measured the deformities of radius as well as ulna of 3 different axes. In which the radius deformity was measured in valgus, varus, and pronation or supination and extension. And in this article, it was found that in radius, extension and pronation deformities are more common, especially in the proximal malunions, and in ulna, valgus and pronation deformities were more common. By the way, if anyone would want to go through this article, you can scan the QR code and you'll get the article. So ultimately, we decided to opt for the fourth option, that is a direct procedure. We removed the ulnar plate and did direct procedure. This was his range of movement at post-op directs, which we have managed to achieve some amount of pronation. And he's still working at the physiotherapy, and gradual pronation is being achieved. Thank you.
Okay.
Excellent case. Excellent
Yeah.
case. Really
Thank you, sir.
stepwise how the reconstruction has taken place to get back and understanding what is the need of the patient and to restore for the function was really an excellent procedure.
So I would like to,
yeah.
Sorry, sir. Please complete. Then I
Okay.
will. Yeah.
No. You go ahead. No problem.
Yeah, so for I would like to just summarize the entire 2 years of our efforts in managing this complex elbow trauma reconstruction. Is from day one we were thinking about plan B, and he was also quite motivated. Our challenges were, comminuted fracture, proximal, in the capitulum as well as radius ulna. Second, our challenges was complete loss of forearm extensor muscle mass. So we were aware that during the debridement, we were aware that he's never going to have wrist, finger, and thumb extension. Okay, because they were from the origin, we had to remove them because of muscle necrosis. Then our third important challenge were about the infection. Of course, with the aseptic precautions, we could get rid of it. Now, after the bone healing, when he came to us for challenges to have, wrist drop, finger drop, and thumb drop correction, our ideal donor for tendon transfer is pronator teres for wrist extension. But because the injury was on the radial side of the dorsal forearm, the even pronator teres was as a donor we didn't have. Then he also, the only donor. That's why if you see, there are only few case reports where FCU, flexor carpi ulnaris, is used as a single donor for considering all three transfers. Okay, so but in this case, we have not done any transfer for wrist extension. We have done flexor carpi ulnaris to only extensor digitorum communis, all finger extensor, and they are causing wrist extension to more than grade 3 extent, grade 3 motor power. And luckily, his palmaris longus was unaffected, his volar aspect of the forearm was unaffected, and we used palmaris longus to extensor pollicis longus. Now, my third important point of discussion here is as Dr. Manish mentioned about having, he is a being IT professional, he wanted to use mouse and he wanted a pronation of the hand. Why did we choose ulna directs, distal ulna excision? Is even, I know this is a suboptimal result for him to have pronation, but to get better pronation than this, if he doesn't achieve, now he is not very, only 4 months post surgery, if I'm not wrong. So maybe rehab is going to make his 20-degree pronation more. But in future, if he desires to have good pronation and mid-neutral supination, if he is happy, we can use proximal ulna and fix it with the distal radius. Okay, proximal ulna with the distal radius, but we cannot reverse it. And that's why we have right now chosen as a direct procedure, because we can sacrifice distal ulna. Okay, when we talk this, I am talking about one bone forearm procedure. One bone forearm, where if you keep the proximal radius, the pronation is always better. Okay, so in one bone forearm, the distal ulna is not fused with the proximal forearm. It is always the proximal radius with distal radius with proximal ulna. So these are where the salient features. But yes, patient was also quite motivated. And third important point in any complex open injuries is intactness of peripheral nerves. His radial nerve, ulnar nerve and median nerve were functional, and he had muscle loss. Otherwise, if there is a nerve injury, joint proprioception and then rest of the function is extremely difficult to achieve. We could use flexor carpi ulnaris and we could use palmaris longus, which is innervated by median nerve, and FCU is innervated by ulnar nerve. That is only because his nerves were intact. So these were the challenges, but at present also patient is partly happy because his pronation has improved only 20-degree from mid-neutral. But yes, we have not given that option to him that convert it to one bone forearm, because otherwise he will lose his integrity in rehabilitation. So because he is very keen to get the multiple surgeries done. Okay, but we know the pros and cons. So let's hope for the best.
We know
I'm
our
happy to
limitations.
answer all the doubts. Yeah, thank you, sir. Thank you.
Yeah, Ravi, you wanted to ask something?
Yeah.
Yeah.
It was really a nice presentation. Actually, case was really excellent. So my question is to Dr. Manish or Dr. Lad as well, that you both have managed that case, sir, that in that kind of a soft tissue setting, that much of soft tissue trauma and that kind of a injury, how often you do the internal fixations and whenever it is required for both the bones, forearm bones. So, don't you think infection is a bit concerned at that point of time? Because getting rid of infection is a bit too difficult as compared to managing the soft tissue conditions like that.
So, a very good question. So, it all depends on the mechanism or mode of injury. And here, the side swipe injury, it is not at all a contaminated injury. The bus, he had kept the hand out and the bus dashed him. So, we don't anticipate much of the soft tissue contamination like a road or a farmyard or something like that. Second is there are enough papers from Ganga as well as all over the world that fix and flap or debride, fix and flap or debride adequately. So honestly, we believed in our debridement and we just temporarily stabilized it. And when we took him for second look or second debridement, we had sent cultures. And that cultures were completely negative. We usually send two cultures: intramedullary soft stick, intramedullary collection, as well as the muscle soft tissue contamination. And third important, of course, the place of fixation is very near, but that was because this was the proximal third radius ulnar fracture, the best stability would have got only by hitting probably, because nailing would not have given a adequate rotational stability. And micro movement and rotational instability can also add up to some kind of micro trauma and leading. But to answer your question, nowadays, yes, we have to take the chance if you are confident enough in debridement, wound lavage, and your culture reports. We have limited choice, but every time we used to explain the patient that yes, the risk of osteomyelitis as well as the infection is always there, and you have to cover these wounds as early as possible, and we should not compromise in in putting only graft or something like that. So if these wounds are covered with well vascularized flap, that also takes care of the drains lot of aseptic contamination or septic contamination. So this luckily we could get away with skin grafting only, but we were very prepared with abdominal flap or with our plastic surgery colleague. So you have to flap and cover the wounds as early as possible. So that is
Yeah,
the key.
definitely. Debridement is
as a rule-
definitely the most important thing. Yeah, Dr. Manish.
Yeah, and as a rule, even as Dr. Parag also said rightly, initial debridement also, post debridement also, we take a swab
Okay.
just to confirm.
Yeah, definitely that's most
And,
important.
and again, because the elbow also was unstable and the fracture pattern was quite proximal.
And
And as
regarding
everyone knows that the elbow is so notorious to get into stiffness. And him
Yeah.
being a right hand dominant, we wanted him to achieve an early range of movement as early as possible, at the same time achieve the best possible functional outcome. That's the reason why we decided for that.
Nice. And regarding that loss of pronation supination, what my take is basically just comment on your take that in these kind of severely comminuted proximal radial and ulnar fractures, and when they present with this kind of soft tissue injuries, means elbow soft tissue trauma and a complex trauma. So most of the times we need to be very much assured enough for the perfect fixation. As you have rightly pointed out that stable fixation is most important. Along with that, the anatomical alignment is also important sometimes in order to avoid that pronation supination loss. Because I think in this case, the loss of pronation supination is proximally actually. The cause is proximal.
Correct.
The malunion of the proximal radius and ulna. And as it was fixed perfectly with the plate, so that's why there was no scope of further macro motion or non-motion, because whenever the patient will try, then definitely he will not be able to do that, compensate.
Right.
So that's
Excellent comments. Ravi.
Okay.
Dr. Himanshu, any questions?
No, sir. Thank you.
Thank you. Deepak, anything? Any questions from your side?
No, sir. All
Okay.
we are here to read. learned.
Just one question. How do you decide whether, of course, there's a plate there and fracture is united, correct?
Yeah.
Yeah. Whether to do a direct procedure or to exercise the head of the radius
Oh.
for improving pronation and supination. How do you decide that?
Yeah, Dr. Manish, is it okay if I take this question?
Yes, sir, please.
Yeah. So, sir, if this would have been, only because there is already a lot of soft tissue trauma and soft tissue cover done by plastic surgeon, we did not want to enter into the zone of proximal radius. That is number one. And number two is right now, probably, excising the proximal head, excising the radial head in a proximal third radius shaft fracture, in my opinion, will not give adequate pronation, pronosupination. It will not improve. Second thing is biomechanics of wrist. Usually the ulna head rotates on the sigmoid notch of distal radius. So the distal pronosupination occurs at ulna, not at radius. Okay, so radius is a constant segment and ulna rotates. So here, if you want to improve rotation, yes, you have to fix the proximal part, that is fine. But here what we can, take out, the only force that is there is a distal ulna. And so to answer your question, we didn't want to enter into the zone of trauma again. And the second thing is the only virgin area left was distal ulna. And third thing is, yes, we were aware because of the interosseous membrane injury, soft tissue injuries, we will never get a full pronation as desired by the patient. And if he desires to have more, then one bone forearm cannot be attempted if you excise the radius, proximal radius. Though these were the points we considered for direct procedure. Yeah.
Okay, and moreover also for excising proximal radius, probably you might have to take the plate out.
Yeah, we have to take the plate out as in nightmare. Yeah, because there is, see, the plate has been fixed from the wound itself. So we were not sure whether we have to go from volar side or dorsal side. And the moment we take an incision on a skin graft, our plastic surgery colleagues, they will again be in trouble, So that's why we didn't want to enter into the territory which was silent. Yeah.
Okay. Thank you.
Thank you,
Thank
sir.
you. That was an excellent case, very difficult case, and managed really that stepwise management I liked.
Thank you, sir.
Thinking about the problem, then how to solve the problem, then stepwise approach reconstruction. Excellent case. Thank you, Dr. Manish and Dr.
Thank you,
Parag
sir.
for the
Thank
case.
you,
Thank you,
sir.
sir.
Thank you.
So, friends, we are almost, I think 10, 11 minutes over time. And thank you again, all the speakers and all the moderators for your valuable time towards academics. Personally, I learned a lot, and also our viewers must have learned a lot about these cases today. We thank OrthoTV also for being there, Dr. Ashok, Shyam, Dr. Neeraj, Bijlani, Poonam, Rishi, the OrthoTV team. Thank you very much. And I thank also personally to Dr. Deepak, Gautam and Dr. Mrinal Sharma for being present there today. Now over to Dr. Deepak for concluding remarks.
Thank you all. Thank you all the speakers and the moderators for taking out time this evening for this cause of academics in orthopedics. We'll be back again after 2 weeks in another subspecialties of orthopedics, arthroplasty, arthroscopy, and tumor. So you can encourage your fellows or your colleague to present an interesting case. You can send me directly into WhatsApp or to Dr. Mohanty or Dr. Mrinal Sharma or Dr. Ashish Phadnis. Thank you for the evening tonight. Thank you all.
Thank you. Good night.
Good night.
And
Good night. Good night. Thank you.
thank you. Thank you.
Poonam, you can stop the live stream.
Poonam ma'am?
Yes, sir.